All right, guys, I think we're going to get started. Thank you all for coming. I think we have a really great case for you. We have Dr. Reynolds here to run through CPC with us. So here are Carl's stock selections and everybody else's disclosures moving forward. So welcome back to CPC. I know you guys are all familiar with what this is. Today, we are talking about the case of a 62-year-old woman with a past medical history of type 2 diabetes and osteoarthritis, presenting with dyspnea on exertion and hearing changes following a flight. And our expert clinician today is Dr. Daniel Reynolds. So meeting Dan Reynolds. He's an assistant professor of medicine here at WashU. He's in the Division of Pulmonary and Critical Care Medicine. Did his undergrad at Creighton Medical School at University of Chicago, residency in chief here at the Mayo Clinic, and fellowship at a place called WashU. Again, 62-year-old, diabetes, osteoarthritis, dyspnea on exertion, and hearing changes following a flight. Dan, what are your initial thoughts?
Yeah, my initial thoughts were, I forgot I agreed to do this. Maybe I could feign some sort of illness. But barring that, I put this together. So my initial thoughts obviously need more information. It's very vague, very non-specific. So dyspnea obviously is a very common complaint, has a very long differential. The hearing changes is a little bit unusual, and we want to know more about what that means. You don't often think too much about hearing symptoms and pulmonary symptoms at the same time. But you'd want to know, are there any chronic symptoms? So, I mean, are you saying she went on a flight and got off and is now really short of breath and can't hear? That's different than she's been a little bit short of breath and it's worse after this flight. The hearing changes are worse after the flight. So some more information on the duration, any kind of fevers, chills, night sweats. Does she have an upper respiratory infection? I mean, hearing changes after a flight are not uncommon, especially if you have, a cold or something like that, you get ear fullness. Changes in pressure can cause some muffled hearing. Any medication changes. And again, what does hearing changes mean? I mean, I think, like a lot of, I say this a lot in the NICU. I'm like, I don't understand. What does that mean? So, can she not hear? Or is it just kind of quiet? Is there tinnitus? Things like that. Again, how long have they been present? Any other respiratory symptoms? Is she coughing? Is she coughing up blood? Things like that. And then kind of just going through specifically, so is the flight related? I don't know what that means. Like after a flight, again, did you get off the flight and it didn't go well and they had to call an ambulance? Or is it just like, hey, I took a flight 2 weeks ago and I'm feeling kind of poorly since then? When we think about respiratory symptoms at a flight, the classic things you hear about are a pulmonary embolism. I don't know how hearing changes would be related to that, but maybe you'll explain it to me. A pneumothorax, obviously, is something you always worry about after a flight. Usually that's in patients with usually some sort of underlying lung disease or a history of pneumothorax, although I suppose not impossible to present that way. And then the hearing symptoms, as I said, are not uncommon after a flight. You can get some eustachian tube dysfunction, middle ear barotrauma, hearing and respiratory symptoms together. You think about an infection. Do you have an ear infection? You have it'd be a little unusual to develop a systemic infection or pneumonia or something like that. And then always ENT symptoms and pulmonary symptoms. It is CPC. Is it something like a GPA or a vasculitis? Would be kind of a vague description of those symptoms. They usually present a little bit more in an excited manner than that, but something to think about, I suppose.
All right. Well, hopefully we can get you some more context right now. So you are seeing the patient in the outpatient setting, and it's December. They did recently have this cross-country flight during which they had severe pain and sudden onset of hearing loss. And the mystery was actually solved very quickly. They went to ENT. They were found to have an acute TM rupture. They underwent tympanostomy. Hearing was getting a little bit better. She does note that prior to the event, doesn't have any long-standing like otic or ENT-related diagnoses, but has had maybe some hearing loss that's worsening over the last year, just kind of tinnitus and worsening acuity of hearing. And then she has had maybe an episode or two of acute otitis media treated by her PCP over the last couple of years. At her ENT visit, this is sort of where this breathing came from, is she had also reported, maybe some mild dyspnea with very heavy exertion, and that was quoted in the chart pretty explicitly, but never defined further. She said probably has had some of these symptoms before the flight or before the trip, and then they definitely felt worse after the flight. She sort of associates this with this vague sensation of turbulence in her chest. says that's worse when she's laying on her side. And then the ENT and PCP together sort of refer her to pulmonary and cardiology to look further into these symptoms. Does that give you any clarity?
Yeah, I mean, I think that's helpful. Again, so we have chronic symptoms that it sounds like she's been having some ENT issues for a little while. She's had acute otitis media, which, a little unusual, I think, for somebody in their 60s. I don't see a lot of patients in the primary care office anymore, but that seems kind of strange. And then she has this acute rupture of her tympanic membrane, gets surgery, and then, oh yeah, maybe I'm a little bit more short of breath, probably going on a while. So again, maybe this flight is just kind of in her mind, she relates it to what's going on, but it sounds like there's something more chronic going on with kind of both ENT and pulmonary symptoms. Unclear, are they related or are they two separate processes? So I think for further evaluation, if you're just seeing her, I think if somebody's reporting that degree of dyspnea on exertion, certainly think about cardiac etiologies in this 60-year-old lady with a history of diabetes, an EKG, maybe a stress test. I'm a pulmonologist, so if she was seeing me in the clinic, I would certainly get a chest X-ray. I would get pulmonary function tests, and would ask other questions again. So what does that mean? Dyspnea with heavy exertion? How limited are you by your breathing? Any cough? Any fevers? Any chills? Any other systemic symptoms? Any autoimmune symptoms? Things like that, and kind of use some of that initial testing to guide where we're going.
Perfect. Sounds good. So let's get you some history. So I'm not going to necessarily read this up, but I will comment on the highlights. Basically, type 2 diabetes, it's actually quite well controlled. Worst ever was an A1C of 7. Most recently, it's 5.9. She is on metformin and Jardiance for her diabetes. She does have this surgical history noted here. Family history is not particularly exciting. And then social history, she works as an RN at Barnes, actually. And hobbies are playing clarinet in a marching band. And she does that actually, they specifically said marches 12 times a year. So she's very active. Gardens, she's a former smoker, but quit a long time ago. No alcohol use, no notable drug use. And then since you mentioned some ROS type things, so here's her review of systems. And I put in red sort of the highlights.
Yeah, so I suppose I don't really know what the turbulence means. That's an odd description. I've never heard of that. Somebody saying I feel a turbulence in my chest. I would want to kind of further clarify what that means. Is it the palpitations and she's describing it as a turbulence, or is she wheezing, or is she feeling just some rattling in her chest or something like that? That's a little bit unclear to me exactly what she means by that. And then again, I think we're dealing with what she has said so far, which is the hearing loss, shortness of breath, no cough. It's good. And then some cardiac symptoms, but unclear if that's just kind of related to her shortness of breath or represents a primary cardiac etiology.
Yeah, and I guess since you mentioned the room stuff, it's not written here, but no hair loss, no, oral lesions, things like that either.
Okay.
Okay, and then we'll get you a physical exam. So this is how she presented in the office when you're seeing her. So normal vital signs, and then the highlights are going to be in the cardiovascular section.
All right, oh boy. So she's got a murmur at the right upper sternal border with radiation to the posterior chest. She's got some lower extremity edema. From a pulmonary standpoint, you hear the murmur throughout the lung zones, particularly at the bases. Okay, that's interesting. No feeling flushed or anything like that. No diarrhea, anything like that.
No.
Okay. So that's interesting. That's quite. It sounds like a pretty significant murmur that I would get an echo for. And future cardiologist right here.
Yeah,
I think
we'll get you an echo.
Cardiologists have to eat too, so I think it's okay to go ahead and just get an echo.
Okay, we'll give you baseline labs, and then we'll get you an echo first. So here's baseline labs. Not particularly exciting.
Okay.
And then, so let's give you our sort of our menu here.
Wow.
And since you said echo, I think that's a reasonable place to start with this case.
Sure.
So we'll jump right into cards, theoretically. Uh-oh, unless my link's not going to work.
I don't like the sounds of advanced cardiac eval. Call that a clue where I'm from.
So you get an NT Pro 600. EKG has left axis deviation, nothing else exciting. And then her echo. What do you think about this?
Okay. Looks like her right-sided pressures are a touch high. So yeah, RVSP of 92, pretty impressive. So this could certainly explain a lot of her symptoms, especially the pulmonary symptoms, the cardiac symptoms. So we have somebody with pulmonary hypertension, and she's never had an echo before or anything that we know of before.
No.
Okay. So generally in this situation, I would get if I'm seeing her in the outpatient setting, I would get some other information. So some sort of imaging of her chest, a chest x-ray to start with. And then I think you're going to want a CT scan as well. I think, for a new pulmonary hypertension workup, I always get autoimmune evaluations. So what's the etiology? We have 5 different groups of pulmonary hypertension. You have idiopathic, you have due to left-sided heart disease, due to lung disease, chronic thromboembolic pulmonary hypertension, and then a miscellaneous category. So, an ANA, an ENA, an RF, a CCP, an HIV test are all indicated in somebody with new onset pulmonary hypertension, in addition to checking pulmonary function tests, imaging of the chest. And then really, you want to get a right heart catheterization at some point. Again, I don't know what the situation here is. If she's still being seen in the outpatient setting, but if I saw somebody in the pulmonary clinic with with that kind of echo and everything else was kind of coming back reassuring, I would get a right heart catheterization. But we may be getting ahead of ourselves.
Okay, so no, that sounds great and very, very helpful. I think we'll go with Pulm. You mentioned some PFT. I will say chest X-ray, actually don't have an image of, but is normal.
Normal, all right.
Not hyperinflated, nothing exciting.
Disappointing, all right.
But I do have other images for you shortly, but I'll give you the pulmonary workup. So she does get a VQ scan. She actually got just a Q scan, but it was intermediate probability for PE, moderate size defect in the left apex, and then a possibly artifactual, but maybe moderate size defect at the left base. PFTs were pretty unexciting, and then her 6-minute walk test was normal.
Okay, yeah, I mean, so a VQ scan, if you're seeing somebody for work, when Murali Chakanala or Rob Case sees somebody in clinic for pulmonary hypertension, they always get a VQ scan beforehand. And the reason for that is it's important. It's the only pulmonary hypertension group that you can actually cure with surgery. And so Murali has seen people in his clinic for 20 years that have been cured with a surgical pulmonary endarterectomy. So always useful to make sure you're not missing a group 4 pulmonary hypertension. So in this case, we have some probability for PE with some defects. So that's interesting. I think, I would follow that up with a CTA of the chest. Again, the correct screening, for medicine boards, the correct screening test for group 4 pulmonary hypertension is always a VQ scan, but then you usually will follow that up with some sort of imaging of the chest with a CTA. PFTs are pretty unremarkable. That's reassuring. 6-minute walk test is normal. It's a little unusual, I suppose, if she has this severe pulmonary hypertension and a pulmonary systolic pressure of 90 millimeters of mercury, but it sounds like she's walking well and doing great. And so can't argue with that.
Yeah. All right. You said the magic words, which was CTA of the chest.
All right.
So we're going to get you that. And we have Dr. Stacy Kim up here to talk about it. If you want to hold the slides, just don't advance from the last one. Yeah, you can score the arrow.
Right, so first we have CTA chest with contrast, the transaxial images. So going from the left toward the right, we are scrolling through. This is the main pulmonary artery here, bifurcating into the right. And then you can see a little bit of the left there. That's the ascending aorta, that's the descending aorta. So we have what appears to be this thick rind of soft tissue. You have to, I think squint a little bit, but thick rind of soft tissue that's extending a little bit at the bifurcation, but mostly along the right and left pulmonary arteries. It is narrowing them. So here, for example, the right PA is quite narrowed. The left PA is also narrowed, and you can catch a little bit of that on this image. Here are the coronal images, again, showing that thick rind of soft tissue extending along the main PA, going to the right and left PAs. This is actually a little bit of the left PA that we're seeing very narrowed. And then here we're seeing some of that right PA that is again narrowed. And then here is the heart. You can see that the right atrium and the right ventricle are larger than the left atrium and left ventricle, which is not normal. There's also flattening of the interventricular septum. And so these findings, the enlarged right atrium and right ventricle, flattened interventricular septum, perhaps some hypertrophy of the right ventricular musculature there. We don't usually see it that thick. So these findings are all in keeping with the severe pulmonary hypertension that was reported on echo. And then just as a quick comparison, for those of you who are not used to seeing those areas on CT, this is a healthy patient with main PA, right PA, left PA. There's no soft tissue rind. There's no narrowing of that right PA. And then the heart, you have rightward bowing of the interventricular septum. It is not straightened. It's not bowed toward the left. It's bowed toward the right as it should be. And the right atrium and the right ventricle should be smaller than the left. So these findings are all concerning for a possible vasculitis involving the pulmonary artery branches. And so if we were to think about looking for some acute inflammation in those regions, then a PET CT may be of use in looking at that further.
Thank you.
Thank you. Looks abnormal,
Yeah.
to me. So, when I see that kind of narrowing of the pulmonary artery or any, we always think about things like this is like a fibrosing mediastinitis. It doesn't really look like that. There's no calcifications or anything like that. It just kind of has a weird look for that. It doesn't seem like that. There are some kind of rare things that can cause kind of, deposition in the mediastinum, things like that, like IgG4 disease, things like that, rare kind of inherited diseases. But I would think, yeah, vasculitis, especially it's so narrow and kind of blocking off the main parts of the pulmonary artery, on both sides there, that it would seem to be related to that rather than due to a primary pulmonary arterial hypertension. So I guess in addition to the autoimmune workup we mentioned, especially with these ear symptoms, we should send like an ANCA and things like that. We kind of talked about it initially. And a PET scan would be useful as well. I don't know how likely a biopsy is going to be particularly useful. I don't know a lot about biopsying the aorta or the pulmonary artery, but it seems like something I'd avoid. Taking care of patients in the ICU, it's not something we typically recommend.
Yeah. Well, while your autoimmune workup is cooking,
all right,
they did get a PET scan. And we have Dr. Jerome here to talk through the PET scan for us.
Hello, everyone. So I'm a real doctor. I just don't have my lab coat on. So let's look at the PET CT on January 11, 2023. So this is the first PET CT on this patient. Let me put my mouse here. So yeah, as you can see, following up on the CTA that Dr. Kim showed, so there is some area of avidity surrounding the main pulmonary artery. It's better seen on these axial images. So FDG is a physiologic imaging, so it shows the metabolism. And there are a lot of locations that we expect physiologic uptake, not normal uptake, but not in surrounding a main pulmonary artery. So this is definitely abnormal. And as you can see here, it extends along the main left and right pulmonary artery. So it's pretty localized, and it's not going to include other vessels in the body, not large or small vessels. So pretty focal, which is unusual, but it also supports that this is an active process that's going on. So there is a lot of metabolism in that area of narrowing of the pulmonary artery that's active. So again, it suggests an infectious inflammatory process. Vasculitis is a good thought. We can't rule out completely the malignancy, but the uptake level is not too high. So Angiosarcoma usually tends to have much higher avidity compared to this. So this is a good level for an infectious inflammatory process. Do you want me to show the follow-up one?
We can come back to it.
Come back.
Why don't we do that? Okay. So that's what,
There's no uptake anywhere else. There's no mediastinal or hilar lymph nodes that are active, nothing like sarcoid. Yeah, infection, I guess, is another good thought. Be kind of unusual. I'd still be leaning towards an autoimmune as the most likely, but we could think about that as well.
okay. Well, I'll give you sort of autoimmune adjacent. So here's just some inflammatory labs. So ESR, CRP.
All right. Not too bad.
Not too bad. Not normal, not too bad. And why don't I give you urine just because might as well cover it.
Okay. Well, that's a UA with greater than 50 red blood cells. So, I mean, I think, again, that's leading us towards some sort of vasculitic process. You think about like a pulmonary renal syndrome with an active urinary sediment with a lot of red blood cells, a lot of hematuria. Marin Khalif, one of our colleagues, always tells the story. When he was in the military, he got a call from a submarine where they said some sailor was coughing up blood. And he said, check the urine, and the urine had this kind of thing. He said, oh, it's pulmonary renal syndrome. They sent a helicopter to the middle of the ocean. So he diagnosed the guy with good pastures by doing that. So I'm not quite that good. But this is something that's kind of adding to the story here, that this looks like some sort of, if you think about a vasculitis, always checking a UA and just seeing, do you have any hematuria is always a good idea.
Okay. They're back. You got your room, sir.
All right.
Okay.
All right, here we go.
I'll let you interpret this.
The ANCA seems to be positive. MPO is quite positive. PR3 is negative. GPA, I believe, is usually more associated with PR3, but I wouldn't necessarily rule that out. So to me, this looks like an ANCA. This is screaming ANCA positive vasculitis with a very high titer with a kind of maximally positive MPO antibody. So you think about GPA, you think about MPO, microscopic polyangiitis. I mean, this is a large vessel. So I think, I'd be more thinking about GPA and things like that. But this is interesting. So I think I would, and at this point, is she still in the outpatient setting, or
she's shockingly not that sick.
Okay. All right. That's good. We've had no findings on imaging in terms of any lung findings, like no nodules or anything like that. So I mean, from my perspective, this seems like an ANCA-associated vasculitis. I would involve my rheumatology colleagues. It sounds like if the infectious workup and everything like that is negative, and her renal function's been normal and continues to be normal. This seems like somebody that you'd want to start on some steroids. I'm a pulmonologist, so I mean, steroids always are the right answer. Right. Would start her on some steroids and see what her response is to that. It's kind of interesting with this degree of pulmonary hypertension. If it really is, all from this vasculitis, you suppose that might be able to get a little bit better if you can improve that degree of narrowing. But that's the top of my differential right now, is an ANCA-associated vasculitis. Totally fair.
And you've mentioned infectious. This isn't, I'm sure, not really the infections you're talking about, but
RPRs.
Just for completion's sake. I don't actually know if she ever got an RPR, but regardless, nothing exciting here. And then you did mention right heart cath, and that did end up getting completed. So I'll just give you those numbers just so everybody has seen them, because they are notable. And I will say that the right heart cath was done after the CTA, so they were aware of these stenotic areas on both the right and left PAs. And so they did both do a main PA and try to thread left and right. And they actually couldn't pass a wire through the left. It was so stenotic.
Yeah, it sounds dicey. So the right atrial pressure, not too bad, 5. The right ventricular pressure is obviously quite high, 72/6. Pulmonary artery pressure, 48 systolic, 12 diastolic, with a mean of 24. That's not that high, 24, mean pulmonary arterial pressure, 24. When I was a fellow, which wasn't that long ago, I think you had to have a mean pulmonary arterial pressure of 25 or higher to have pulmonary hypertension, and they subsequently changed that to 20 for, I don't know, a variety of reasons. So she has some degree of pulmonary hypertension. She has a PVR of 3.6 Wood units, which is a little bit elevated. Cardiac output seems normal. Her wedge is normal. So, I mean, some mild pulmonary hypertension. But again, in this setting of this severe stenotic vascular compromised. I'm not sure what to make of those numbers and how accurate they are.
Yeah, fair enough. Okay, I think we've actually done our whole menu. So do you want to summarize? Because I will say, you mentioned biopsy. You were also correct. There was no biopsy performed primarily because of the location.
I think this is a lady with, some hearing loss, recurrent kind of issues with tympanic membrane rupture and otitis media, likely underlying to ANCA-associated vasculitis in the setting of pulmonary hypertension secondary to these kind of stenotic lesions in the setting of active vasculitis is what I think is going on.
All right. You nailed it.
All right.
That's it done. All right. So just to give you guys a little context about our hospital course. So you are right. So PR3 is the more classic GPA type of ANCA. And MPA, microscopic polyangiitis, is more commonly associated with MPO. That said, there's about 20 to 30% of overlap between the two. And this lady was, of course, referred to rheumatology, and they did formally diagnose her with GPA, primarily because of the heavy ENT involvement. And I buried the lead a little bit with that because she's been having probably more ear problems than we gave her credit for, but truly had never had a formal unifying diagnosis prior to this. When Rheum saw her, she was started on avacopan. She was also placed on a pred taper and rituximab. She was actually on rituximab for over 2 years. She was just seen at her Rheum follow-up with Dr. Diffie, and I think like less than a couple weeks ago was transitioned over to azathioprine. She did undergo bilateral pulmonary artery stenting, and very impressively pretty much cut all of her pressures in half. Her latest echo had only mild TR. Her PASP is down to 35. So she's doing much, much better. And since we have the post-treatment PETs, not post like 2 years treatment, but post a couple of months treatment, we can actually go back to that because it's interesting. If I can get back. So here's post.
So it's only 7 months after the prior imaging. So it's, as you mentioned, it's not after 2 years, the full cycle, but you can see that the activity is minimally present, but much, much better compared to the original imaging. So this one, it shows a favorable treatment response. So things are going in the right direction. There is still slight activity that shows some active disease, but it's much improved.
All right, and then just to get into some brief teaching points. So pulmonary hypertension, I know most of us are very, very familiar with this, but like you mentioned, 5 groups. We kind of know the groups. This person probably falls into the group 5 diagnosis as like sort of vasculitis associated pulmonary hypertension. That's sort of your grab bag of diagnoses, including some of the really rare stuff like glycogen storage diseases, sarcoid, which I know is a big area in your clinical practice, neurofibromatosis, a handful of random things. Workup is broad for pulmonary hypertension, especially once you've ruled out group 2 pulmonary hypertension, then you start diving into the VQ scans and all the lung studies to make sure it's not group 3, and then really going down the rabbit hole. Frequently end up getting right heart caths in these patients, as this patient went through. And then for GPA specifically, often has prodromal symptoms, frequently has systemic symptoms, fevers, weight loss, night sweats, things like that. This patient did not have those. Can have a diverse sort of manifestations from an ENT standpoint, more commonly seen in GPA than MPA. She obviously had a lot of the ear manifestations. Patients will sometimes have like bloody discharge from the ears. They can have like the saddle nose deformity and kind of erosions of their nares. And then tracheal and pulmonary involvement for GPA is not uncommon, but it usually manifests as fibrosis or nodules, and true pulmonary artery stenosis like this is quite rare for GPA. Kidney involvement is common. It seems like rheumatology was maybe on the fence about how real that hematuria was, but she did continue to have sort of low-grade hematuria throughout her recurrent UAs. It's actually not common at diagnosis, but then almost everybody gets it. So over like 75% of patients end up with it. Derm, ophthalmology, or ophthalmologic and neurologic manifestations are common too. And then sometimes biopsy is done. In this case, biopsy was deferred because of the location. Ultimately, I thought this was an interesting case because this was somebody that probably had a much more prolonged underlying diagnosis or disease with these ear things. And then with this flight leads to a TM rupture and then sort of incidentally mentions this shortness of breath. And so I think it was an interesting demonstration of how an acute event can sort of unmask an underlying diagnosis that's been building for years. So cool case. And
yeah,
thanks,
it's
Dr. Reynolds.
interesting. Like the pulmonary involvement, this is a nice example of kind of somebody with like not predominant really like pulmonary parenchymal involvement. Most of the time when I see GPA, it's in the ICU where they have diffuse alveolar hemorrhage, they have cavitary pulmonary nodules, and that's when we debate, doing high dose steroids, Plex, things like that, that there's kind of limited data for. But in this situation, you have an outpatient who's clearly presenting with ANCA-associated vasculitis, and there's good data for kind of some of the interventions they mentioned. So I've never seen pulmonary artery stenosis from primary GPA, so I guess now I have. Maybe it's seen me before, but I haven't seen it.
All right. Well, thank you so much.
Thanks.